Okay, go
All right, so we have a case here. So we have an 83-year-old man. He had a recent decline in his left eye. He was receiving treatment for wet macular degeneration from August in 2013 with Avastin and Lucentis. He had another treatment done. I kind of took that detail out because that was a hint. 2 years ago, he seemed to respond well to that. And he returns with further vision loss in that same eye. His medical history includes aortic ectasia, hyperlipidemia. He's got allergies, arthritis, some basal cell, CKD, AFib, hypothyroid gout, and depression. He's had some surgeries all the way back, going back to 1948 with his tonsils. And then he's taking allopurinol, alprazolam, Buspar, levothyroxine, and some multivitamins. His vision in the right eye is 20/63 and the left eye is 2200, and his baseline was 2160 before he noticed this recent loss. His pressures are 13 and 17.
Fundus photo of the right eye. Not sure if the media is clear. It looks like a large cup, some peripapillary atrophy, or pigmentation. Tough to say. Vessels, they look hazy going inferiorly, so I'm not sure if there's just a bunch of floaters in the way. Spiraling out from the center of the macula is this pattern of white dots, hypopigment lesions, some bigger than others, probably consistent with macular drusen.
Yeah, good. My guess for this haziness is like a small YAG. I don't think it's relevant. Just catching the edge of a PCO probably.
Okay. Fundus photo of the left eye. Similar findings, except that PCO is not present. Scattered hypopigmented lesions, and of course this large, probably pre-retinal hemorrhage throughout the macula. Subretinal.
Can you see the vessels? Look at relative.
See the vessels down below.
Oh, yeah. There, okay, so that's.
I mean, it's red on red, so it's
That almost exactly like Martha's Vineyard.
Pardon?
Is that, I don't know if you've seen pictures of Martha's Vineyard, but I think that's Martha's Vineyard.
I don't.
Pull it up. Keep going, I'm gonna pull it. I haven't been there in a long time.
All right, so anyway, it's interesting. There's some, looks like there's just areas of clearing in the blood, and I believe
I wasn't involved in the first one.
Oh,
The area you say actually has within it a darker red area. It's not bright red.
Okay.
That may or may not be
the choroidal hemorrhage.
sub-RPE.
Yeah. The CT of the right eye, some PEDs temporarily, a little ERM.
I would go drusen. You use kind of a lead. You know?
Yeah, well, one PED, then some pseudo.
Yeah, good. Just some of those outer changes.
Yeah.
Left eye, a lot of architectural disruption, intraretinal fluid, serious PED, drusen temporally. It's probably some thickening of the inner layers.
And then on the color picture, you saw red stuff, right?
Mm-hmm.
So where would that be on the OCT here?
Could be in the inner retina, or that that sub, RPE blood we thought we saw as well.
Or subretinal, right? Based on the, subretinal, based on the pattern.
And then this PED, would you describe it with any particular shape?
Yeah, shaped, and it looks pretty thick, so I was thinking it's RPE.
Yeah, maybe peaked PED.
Oh, yeah. In that so the subretinal hyperreflective material, just temporally, put your little red guy on that, go up to
This
the
one?
right. No, that guy. So that's probably the blood. So the blood on an OCT shows up as generally, it's almost always subretinal, right? It shows up as hyperreflective, sort of where you expect to see fluid. You see this hyperreflective stuff, that's blood, which is bad.
FA.
Yeah, this is FA. I think we just have a couple. We're mostly focusing on the left eye, so just a couple on the right, I believe. So this is at 1:35, minute 35. And then at 17 minutes.
Wow. That's patient.
So what are those spots, those little increasing hyperfluorescence temperature?
Right.
What are the
Staining and bruising.
good? Yeah, staining is a good word because it's fluid going into a solid space. They're staining, they're not cooling, they're not leaking, they're staining.
Very dark, well, surface charts. Oh, yeah.
Okay.
And then moving on to the left eye.
Very early in the beginning, pigment. I see a private window defect. Or, excuse me, blocking of the blood.
Yeah. Oh, so
Right.
so this is, I don't like when they do this, but this is FA on the left, ICG on the right.
Right, yeah.
So you're seeing the FA on the left and ICG on the right.
Both are injected at once.
Yeah.
You did like a mixture of the.
Yeah.
Yeah, a little cocktail.
Oh, yeah. You actually did inject both at once?
Yeah, they mix up. All right, so what do you see going on there? So what phase is this right here?
I mean. Yeah, very early, and this is.
But is it
early arterial?
arterial? Good. Okay. We'll keep going. And then how about now? What phase is that?
Looks like we just got into laminar,
Okay, good.
early laminar, and you can see that this not pre-retinal going over the blocking.
Good. Can you guys hear okay on the internet? Are we talking loud enough?
Yeah.
Okay, good.
On the right,
I think
that's
both FAs.
is
They're both FAs now.
Yeah. Well, the blocking of the blood.
yeah, and then you can see that there is that window within the blocking, so if you were to transition through, and then maybe a little, yeah, exactly, right there, early leaking, pooling, not sure yet.
Yeah, it's about 1 minute and then about 4:40. So some leaking.
So your edges are definitely, are their edges changing? Yeah.
Yeah,
Yeah, so it's leaking. All right, good.
All right, and then I think this is just ICGA on the right.
yeah, that's probably blocking from the drusen that we saw earlier, otherwise normal. There's also ICG.
Yeah, this is ICG.
Yeah, so you got 1 minute and 5 minutes.
Okay, so hyperfluorescence of cyanosis, these lesions in the nasal macula there, just temporal to the disc. It looked to be the same size as a staining of, maybe some neovascular membranes. It's ICG.
Good. And what about those big, there's a couple things, these are kind of buzzwords, but do you see a vascular network there? like an interconnecting or branching vascular network by the optic nerve.
Hmm. I don't see it, but I think you see it.
No, it's not really obvious. I mean, it's possible, these big vessels are choroidal. I'm right where you are too, but these little guys, so I don't really see a great vascular network. But then how about these big things here that are just kind of at the edge of, sort of lined up, yeah, almost like a, oh shoot, I forgot to get up and watch the eclipse. It's almost like a crescent moon.
Yeah, I did too, but it was what, 2 or 3 in the morning?
Yeah, I can look out the window. It's just in the morning. So yeah, so the like a crescent, what about those? They're.
I mean, I don't know if it's, like I said, staining or if it's just, yeah. The neovascularization.
Yeah, so it's neovascularization, say it's neovascularization, it's filling, pooling, there's a dye pooling there in these things, there's like 1, 2, 3, 4, 5, 6, 7 of them, 7. Okay,
There's also something infratemporal to center where that, I said that dark red stuff is.
yeah,
So if you look, you can see there are 2, one spot there and up in supratemporal to that, another spot, and they are increasing. So I think that's a hemorrhagic, RPED.
right,
And that it's one of those vessels, the first one I mentioned is within it. And the other is probably creeping out from its edge.
Mm,
I think that's pretty diffuse disease.
okay. All right, so keep going.
Okay, so now we're at 5 and 16 minutes. Just kind of showing a little more these lesions.
Probably increasing in size.
And the other important thing is the timing, so that one on the left is before 6 minutes. So if you get these things that earlier, like 5 or 6 minutes in, that's of some importance.
The one, most extreme one on that string is increasing. No, not there. Back up where he's talking about. Little down to the left. There, that one is increasing.
Yeah.
So that's, and up above the one supratemporal is fuzzing out a little bit too. And I'm not good at ICGs, but that's a red flag for neovascularization.
And then one interesting detail that we might talk about later is there's like a surrounding halo of hypofluorescence around the lesions, and that's characteristic. And that in the later stages that tends to get washed out.
And in these, you can almost see little vessels pointing out to the big things. So in these images, you can almost say like, well, maybe that's a vessel. It could be choroidal. Actually, forget that. Those can all be choroidal vessels. All right, go ahead.
Okay. Oh, I think my animation didn't work. Bummer. Oh, there we go. Yeah, so I wanted to line up the fundus photo with the ICG so you can kind of see where those
Nice, that's cool.
things are. If you can see them in real life, but not necessarily in this case, maybe.
Yeah, thanks.
Oops. Okay, so we have our 83-year-old guy with a recent worsening of visual decline in his left eye. And then we have the OCT and the ICG with those lesions and maybe a peaked PED. So what do you think about a differential?
The exudative AMD, choroidal neovascular membranes, broadened PIC, multifocal choroiditis, but top of the differential is probably exudative.
Okay, good.
Yeah, so I got idiopathic polypoidal choroidal vasculopathy, and then exudative AMD, CSCR, some of the pachychoroid stuff, and then other things that can cause choroidal neovascularization and hemorrhage. So yeah, so it turns out so these are the polypoidal lesions of polypoidal choroidal vasculopathy. So that's kind of what we'll talk about. And then that treatment at the beginning that I kind of alluded to was photodynamic therapy that he got on a previous visit. He was treated on the day that these images were taken and then lost to follow-up after that. So we'll talk about polypoidal choroidal vasculopathy. So it was first described in 1982 by Januzzi. It's an exudative maculopathy with recurrent serosanguinous pigment epithelial detachments. It was initially described in Black middle-aged females and later identified in all genders and races. It is almost 5 times more common in females. And then prevalence-wise, one study said that it's about 0.4% of the general population, and that was based in Europe. And Europeans tend to have a lower incidence. So in patients with a neovascular AMD type presentation, so it was about 7.8% whites, 22 to 54% Asian, so a lot more common. And then a lot of the papers say that it's more common in people with more pigment in their skin, but I couldn't find an exact number for Black or African Americans, but I would presume that would be higher than in the white population. So PCV can be classified as quiescent or active. In the quiescent stage, you have polyps present, but there's no subretinal hemorrhage or epithelial detachments. And then in the active stage, you have loss of vision, evidence of activity on imaging, sub or intraretinal fluid, PEDs, and subretinal heme. And then you can have an exudative, a hemorrhagic, or mixed forms. So in the etiology and risk factors, so it's basically an abnormality of the inner choroidal vasculature. You have polyp-shaped aneurysms developing a thin endothelial lining between RPE and Brooks membrane, and these polyps have a tendency to leak. It's thought to occur at an AV crossing site with a sclerosed arteriole, and that leads to the venous stasis and that kind of ectasia, I guess, of the blood vessels, sort of reminiscent of a vein occlusion, but we're in the choroid. So I thought that mechanism was sort of interesting.
That's interesting.
And then it's associated with systemic hypertension, blood hyperviscosity, and thrombocytopenia. So on presentation, patients can have decreased vision, metamorphopsia, central scotoma, or floaters. It's usually bilateral. If it occurs in one eye, the fellow eye will usually follow and have a similar appearance. Large polyps may indeed be visible on just a retinal exam, and they're described as a red-orange subretinal nodule, and I'll have a picture of that. Most commonly in the macula, but they can also occur around the nerve. And then they can have serous or serosanguinous pigment epithelial detachments and subretinal hemorrhage, like we saw our large subretinal hemorrhage in our patient. There's lipid exudation and intraretinal cysts that can indicate chronicity, as well as subretinal fibrosis, pigment epithelial hyperplasia, and retinal atrophy.
What about that peaked PED finding you were talking about earlier? Is that
Yeah, so that can be a characteristic as well. So there's like peaked and notched, and we'll get into that in a couple slides, I think. But yeah, that's also potentially a characteristic of PCV. So here's just an example on fundus exam of a large, that red-orange subretinal nodule that you might be able to catch just on your retinal exam. So ICG is the sort of backbone of imaging for PCV. It provides improved imaging of choroidal vasculature over fluorescein angiography. And just a quick review on ICG. So ICG is the dye, I guess, a stain, and it's 95% bound to protein in circulation, and it doesn't leak in the choriocapillaris, I think because it's a larger molecule, so it doesn't leak out of the holes. And compare that to fluorescein, which is bound at 80%, so that tends to leak more. And then the ICG will emit at 835 nanometers, which is in the infrared, versus fluorescein will emit at 512 to 520 nanometers. And so for this reason, that's why in the FA we had all that blood that was blocking our view of our polyps, but then we could see it on the ICG. And then just to kind of illustrate that, so this is like an absorption spectrum of your retina with like the RPE out here and these lines. And you can see that in the range of the FA or the fluorescein, it's going to get absorbed at a high percentage. But then with the ICG, you're over 800, so you're going to be out here where there's very little absorption, so you'll get a better view behind the retina into the choriocapillaris and the choroid. So on ICG, you can see an abnormal vascular network of interchoroidal vessels, which is kind of what Dr. Cohen was alluding to on that one picture that we had. There's nodular dilations at the edge of this abnormal vascular network. And then you can have a hyperfluorescent halo around polyps that occurs within the first 6 minutes. Late leakage obscures the halo, and then polyp pulsations may be observed. I couldn't find a way to incorporate it in the PowerPoint, but it's very easily Googleable and pretty cool if you want to try to look that up. You can see these polyps kind of pulsating.
On Fundus or?
On the ICG.
On like ICG.
I have a GIF. I'll find. I have on one of the websites. I have a GIF on the Retina Gallery one. I have a pulse signal that I saw pulsating. That's one of the reasons I like to be there when I like to do the push on a lot of my patients, because the photographer would never pick that up. But if you see it pulsating, then you can catch a video, which is kind of fun.
Yeah, so ICG will reveal the polypoidal lesions and aids in PCV diagnosis, and it can identify areas for treatment with photodynamic therapy, and then also if there are recurrences. So here's kind of that abnormal vascular network with your polyps kind of at the terminal ends of that. And then fluorescein angiography is recommended as part of the initial evaluation. It'll show leakage from the abnormal vascular network, and that indicates activity. It will likely overestimate a lesion size compared to ICGA, and it has a limited role in diagnosing the polyps. So here's just an example of, I believe this is FA on the left and then ICG on the right. Kind of the same retina. The lesions look a little bit larger on the FA than on the ICG. So OCT is also useful. It may increase suspicion for PCV, but it's not recommended for diagnosis alone. It's good for monitoring the response to treatment. So at the location of a polyp, you might see a peaked PED. So that's something that we kind of maybe had in our case, peaked PED on OCT. You can also have a notched PED, which may indicate an occult choroidal neovascular, or an occult CNV. You can have a hyporeflective lumen surrounded by a hyperreflective ring under the surface of the RPE. You'll have that double layer sign, which is RPE separated from Brooks membrane, and that can indicate presence of an abnormal vascular network. And then pachychoroid. I think in our case, he didn't really have a super thick choroid, but that's PCV is on that pachychoroid spectrum. So you can also kind of take a look at the choroid. And that's a good way to differentiate from AMD, which tends to have a thinner choroid. And so it's just some more examples of stuff from the literature with a peaked PED. Doesn't look super peaked to me here, but it is taller than it is wide, so that might be kind of what they're indicating. And then another example down here. And then there's a notched PED. And double layer sign. And Brian kind of showed us a nice double layer sign earlier too. RPE separated from Brooks. So management. So if it's active, you treat it. If it's inactive, you can closely monitor. And then if you have active but asymptomatic or peripheral disease, it's kind of up for debate. And the mainstays of treatment are photodynamic therapy, anti-VEGF, and laser photocoagulation. So photodynamic therapy is a verteporfin dye. It's injected IV. It acts as a photosensitizer, and it works by accumulating in abnormal endothelium of those abnormal choroidal vessels. It absorbs light at 689 nanometers, and then a laser interacts with that verteporfin dye and causes singlet oxygen concentrated where it's accumulated in that abnormal endothelium, and that results in vasoconstriction, thrombosis, hypoxia, and vasoocclusion of the abnormal vessels. It has a half-life of about 5 hours, and so you want to wait like 5+ half-lives for something to be essentially eliminated. So patients should be advised to avoid the sun for 1 to 2 days. And then the spot size is important. It should cover the whole lesion, and then ICGA will give you a good measure of how large a spot size to use. If your lesion is larger than the largest available spot size on your laser, it's recommended to load with anti-VEGF first. And then complications of photodynamic therapy include subretinal and suprachoroidal hemorrhage, RPE tears and atrophy, choroidal ischemia, a secondary CNVM, and retinal fibrosis. And then you can repeat ICGA after 3 months, and PDT can be repeated as necessary. Anti-VEGF is also important in the treatment of PCV. The schedule that I kind of found that people were using seemed to be like 3 monthly injections for like a loading dose, and then they would kind of go to PRN after that. Generally, most patients will have improvement of edema, but polyps persist in most cases. If you have recurrent edema in somebody who you're treating for neovascular AMD, you should maybe think of PCV and check an ICGA to see if they have some polyps kind of hidden that you're not detecting otherwise. And then there's no clear anti-VEGF agent that's been established as a preferred for PCV.
And I generally would not PRN these people. I treat them as wet AMD, so they just get treat and extend.
Treat and extend.
VEGFs.
So combination therapy is combination of anti-VEGF and photodynamic therapy. And there's a whole bunch of different clinical trials that went on and with this, and basically started with the PDT, I think, was out before anti-VEGF. And then the Anchor study compared ranibizumab to PDT alone, and found that ranibizumab was superior to photodynamic therapy alone. And then all these other studies, Everest, Protect, Focus, and Radical, showed that anti-VEGF plus or minus PDT, they compared the two, and that combination was better than anti-VEGF alone. But there's some mixed results. So these 2 other studies, Planet and Denali, found no benefit of PDT plus anti-VEGF over anti-VEGF alone. So combination is probably better, but it's
Yeah,
not
and some resistant
unanimous.
people. And some of the studies had different, some of the studies looked at vision and some looked at fluid. And if you look at fluid,
Okay.
the PDT is better, but when you looked at vision, it might not have added much. But it's like most patients nowadays, we have so many choices that if you have someone who's a little resistant, sometimes throwing in the PDT really helps.
Yeah. Cool. Then there's also laser photocoagulation, and it's generally reserved for isolated extrafoveal polyps. You can selectively target a feeder vessel that's visualized on ICGA. You can have, as a complication, hemorrhage or scotoma or a secondary CNVM. And if you have a really large lesion, then PDT is preferred.
Yeah, I don't think anybody's lasered macular degeneration in a long time. I think that's kind of gone.
No mas. Okay, and then finally we have prognosis. So polyps less than 1 diameter generally have a good prognosis. But poor prognostic indicators include large lesions, PEDs, clustered polyps, macular location, Caucasian race, and a recurrent lesion. About a third of eyes will end up with severe vision loss, and recurrence can occur late, so long-term follow-up is necessary. And that's pretty much it.